Okay, good to get started, Summer.
Yes, let's go ahead.
Okay, great. Well, I'll go ahead and get started. For those on the call that don't know me yet, my name's Allie Kendall. I'm a clinical track faculty with the Nephrology Urology Service at NC State. My main interest in ACVNU lies in minimally invasive urology and advanced procedures. So I chose this paper because we have been discussing it a lot recently, probably because we've had a lot of cases recently that have benefited from having a temporary stent placed. And then talking to some other colleagues, some people hadn't heard of the paper or seen this technique done before. So that's why I want to present it today. So this was so this article was in 2022, I believe, is evaluation of temporary urethral stents in the management of malignant and non-malignant urethral diseases by Dr. Jody Lulich. And so just as an introduction, when we look at causes of urethral obstructions, obviously everyone on this call knows that they can be life-threatening and often need immediate relief. Some causes, most commonly, is going to be neoplasia or urothelial carcinoma. That picture on the right is a cystoscopy image of a dog we just had recently. Proliferative urethritis, blood clots, urolithiasis, urethral strictures, and urethral foreign bodies. Options for relieving urethral obstruction are placing indwelling urinary catheters until the obstruction is cleared, permanent urethral stents, which have always been more of the standard of care, urethral balloon dilations, decompressive cystocentesis, which addresses the stability of the patient, but not necessarily the obstruction itself. Transurethral resection of bladder tumors, or TURBT, which is a relatively new procedure that we've been doing here at NC State, and a few other institutions have been as well. And then cystotomy tubes or catheters that can be either placed percutaneously or surgically. So indwelling urinary catheters up into for a closed urinary collection system can be really advantageous. They can help a lot, but there are some downsides or disadvantages to them. In people, there's a daily risk of infection of 3 to 10% every day that a urinary catheter is left in place. We have multiple papers in dogs, but they're kind of all over the place and usually evaluating other things too. But overall, the incidence of catheter-associated UTIs in dogs is about 10 to 19%. And then the downside is it requires hospitalization and then nursing care to keep it clean and sterile. And then some dogs are just really challenging to even keep them in too. Self-expanding metallic urethral stents have always been a really reliable way to relieve a urethral obstruction. They're relatively quick to place once you know how to place them. But probably the downsides of them is they are permanent. Once they're in, they're in. And incontinence has been reported in 26 to 41% of dogs. So looking at other ways, so urethral balloon dilation can be an alternative to stenting. We've used this for both focal urethral tumors and urethral strictures. So the image on the left is the same image. You're just cystoscopically looking at the balloon, dilating that urethral stricture. And then on the right is the fluoroscopic image. And then you can kind of make out the balloon with the marker catheters. And then that waist, that is where the urethral stricture is. But usually they have to be, if we are talking about like tumors, has to be more kind of focal and amenable to dilation. And then it has been shown to be not as effective in prostatic tumors. Cystotomy tubes or cystotomy catheters, again, can be temporary or permanent and placed either percutaneously or surgically. But these overall do have a high complication rate. Their largest retrospective was surgically placed cystotomy tubes in I think 76 patients. Those ones overall 49% had complications, with 46 being major, which for most of these that was like the tube coming out, but there was also uroabdomens too, and then 59% minor complications. Um, and then the most recent paper, I think 2024 through AMC, showed looking at percutaneous cystotomy catheters, showed 71% major complications, but 100% had minor complications. TURBT is another option, or transurethral resection of bladder tumor. That terminology comes from human medicine, so we're really using it for urethral tumors and not necessarily bladder tumors. But that is one of the standards of care and first treatments for bladder tumors in people. So you can see the image on the left is the same dog at the same area of the urethra. So the top image is a almost completely obstructed urethral tumor. And then down below is post-TURPT. So we use an electrocautery loop to kind of dig out the tumor from the urethra. So works really nicely in a lot of cases, but there is obviously a risk of urethral tear, especially if you transect too deep. So then we started looking at this paper, placing temporary urethral stents in the management of malignant and non-malignant urethral diseases in dogs. And once we learned how to place them, they're very easy to place, cheap, and can be used in a variety of situations. And I'll give some, I have a one case example at the end too, but in the paper, the temporary urethral stents, the main reason for placing them is they're cheap, easy to place, and pretty minimal to no specialized training and equipment. They say in the paper no specialized training and equipment, but I do think, I mean, it's anyone like trying to place a female urethral catheter can sometimes be challenging, and you still usually need at least like a vaginal speculum or something. The goals of the paper were to describe the construction and placement of a temporary urethral stent that was easily manufactured from materials available in most veterinary clinics, allowing the stents to be inserted on demand as an outpatient procedure, and then to also report on the indications and short-term outcomes for their use in dogs with naturally occurring urethral diseases. So the materials and methods, this was from the University of Minnesota. They looked back from 2005 to 2021. They did not have any exclusion criteria because essentially they just looked back through the records on which dogs had a temporary urethral catheter placed. And they looked at the signalment, urinary signs, what the underlying urethral pathology was, and then any of the stent placement details. So indication for stent placement, the duration of how long the stent was in place, and then any of their short-term outcomes. So they had 17 dogs total, 13 spayed females, 4 neutered males, which is not a surprising population given that the large majority was urethral neoplasia, which is also what we see most commonly for urethral obstructions. So 9 dogs had urethral neoplasia, most of those being urothelial carcinoma. 3 dogs had extraurethral neoplasia causing compression, so like intrapelvic tumors, which I thought that actually was kind of surprising. I don't feel like we see that many of those dogs, but maybe they just don't come to us. We just don't see a lot of intrapelvic tumors causing urethral obstruction. And then 2 dogs had non-malignant mural urethral swelling. 2 dogs had functional closure of the urethra of unknown cause, but later they call those dogs functional outflow obstructions. And then 1 dog was for recovery of a urethral tear following a urethral catheter placement. So placement of the catheters Again, when you kind of read through the paper and the description, it can get a little bit confusing. But once you actually go and place one, it's pretty straightforward once you kind of have it in your hands and see it. But in this paper, everything was a 8 French urinary catheter, just a plain red rubber catheter. We have gotten away in some of the female dogs placing a 10 French. So we try to place as big as we can. The catheter length in this study was measured using lateral radiographs. We also, most of the time, if you're placing them, you may also be doing other diagnostics like cystoscopy and or fluoroscopy, so can kind of get a generalized measurement from there. You want to cut the catheter to the appropriate length. You just make sure we made this mistake. I think the first time we tried to place it is not to, you cut the end of it. That is the end that typically attaches to a Christmas tree in a catheter, not the end with the draining holes. And then from the cut side, the cut end is to insert a 20 gauge needle. And then that just allows you to pass suture through to create a anchoring loop, which is a really small loop at the very end, which I'll show you a picture of that. And then placing a safety loop through the anchoring loop, which just basically allows you something to hold on to so that you don't lose the catheter as you're placing it. So this is what that looks like in the paper. So in figure A, that's showing the cut tip of the catheter. And then you're going to place a 20 gauge needle, because that's what usually fits 3/0 suture, directly through the end of that catheter, pretty close to the end, and B, passing the suture from the needle side through the needle. And then in C, pulling your needle off of that, out of that catheter and off of your suture. And then from D, creating that anchoring loop. We found that actually D is probably the hardest part of the entire procedure, just because it's really hard to get a really small loop like that. So it often takes 2 people. Sometimes you need someone holding the stent and putting a pair of hemostats there and the other person tying the loop. Otherwise, that's the time that we found that we either drop the stent on the ground because you're trying to tie the loop, or you like tie it too tight and can't get the loop to release a little bit. So you do want a little bit of space, but you don't want a large loop because that's what's going to be sitting in the vestibule. So you don't want that to be causing irritation inside. So in female dogs, the procedures, it's obviously aseptic or a sterile procedure. You can do it in lateral recumbency. You can also technically do it in dorsal. I think we've done a few in dorsal, especially if we've just finished cystoscopy. In this study, they utilized an otoscope cone to pass the stent into the urethra, but you can also, again, use vaginal speculum or cystoscopy. However, you normally would place a female UCath. Make sure, again, to hold on to the safety loop that's passed through the anchoring loop so that you don't lose the end of your catheter up into the urethra. And then from there, you can either kind of put a finger into the vestibule to figure out where you want to pass your external suture. And so using a suture cutting needle, you pass it from the outside through the skin into the lumen of the vestibule, into the area where you want it to go in direction of the external vulvar opening. You can either grab the needle with hemostats in the vestibule and then pass that needle and suture through the anchoring loop at the end of the stent. Another thing we have found as well is that you can actually pull the stent back a little bit, so you can actually visualize this process so you're not doing it blindly, because then once you pull your skin suture tight, it'll pull the catheter back into place. But then the needle and suture is now passed back through the external opening of the vulva, through the inner lateral wall, and then the skin near the initial entry site to tie it off. And then the other tip is not to tie it too tight, because that's the times that we found that the dogs don't tolerate it quite as well. So this is what that looks like. And so you can see that the temporary urethral stent is placed. And so you have the end of the stent in the bladder with the draining holes, just like if you were to place a normal urethral catheter. It expands the area of the urethral obstruction. And then the other cut end of the temporary stent with the anchoring loop is just kind of exiting out the distal urethra into the vestibule. And then you kind of find that area that you want to pass your suture through. That suture goes through the skin, through your anchoring loop, and then back out and is tied. And that keeps the stent in place. And then also by putting it up here, we found that's probably less irritating. We have found like some of the ones that we suture a little bit closer down to like the actual vulvar lips probably is a little bit more irritating to the dog. The male dogs, similar, same procedure, just different in where you tie it off. But same thing, aseptic technique, lateral recumbency, pass the temporary stent through the urethra, holding on again to that safety loop. And then in this paper, they initially had the suture placed through the lateral prepuce, just proximal to the preputial opening, and then securing that suture to the anchoring loop. In one male dog, they did have to use a 10 French nasal esophageal feeding tube just for that extra length for a large breed dog. But then the picture of this one is from a dog that they had to replace it, and they actually sutured it directly to the distal penis itself. And we found that actually works better than doing it to the prepuce, because I think as the dog is urinating and the penis is moving in and out of the prepuce, it causes less friction on that and less tension on that suture, and probably less discomfort for the dog too. So we just suture it directly to the penis now as well, how this is shown in this picture. So looking at the results, so all the dogs did receive 2 to 4 doses of an antibiotic during and after stent placement. And then removal of the stent's pretty easy. You just cut that external suture and pull it out. Same thing, hold on to the stent so you don't lose it up into the bladder. So that's the time we'll try to grab that anchoring loop with some hemostats while we cut the external suture, and then that gives us something to pull when we pull it out. Their placement was confirmed in all dogs. I think in all of these, they were confirmed with radiographs. And then all dogs were able to evacuate urine and their obstruction was relieved. None of the dogs in the study attempted removal themselves, so they all tolerated the stent well. 16 of the 17 dogs did have urinary incontinence, which you would expect because it's spanning the entire length of the urethra. There was one male dog that had a prescrotal urethrostomy. So his stent was only in the distal urethra. And so he had a much shorter stent and did not have incontinence, likely because it wasn't spanning the entire length of his urethra. So follow-up, again, they had 9 dogs with neoplasia. 7 of those were urothelial carcinoma. One was a leiomyosarcoma, one was lymphoma. 3 of those dogs were euthanized at day 7, 24, and 105, and that was just due to their progressive disease. But all of the stents had remained patent during this time. 2 dogs did at some point have their stents replaced with permanent expanding stents, and that those 2 dogs, that was on day 6 and day 62. And then adverse events, 1 dog did have a reobstruction at day 57 due to the stent migrating. And then 1 dog had the suture kind of dig underneath the skin, but not completely attached. And that was noted on day 61. And that was a dog that was following radiation therapy. For the dogs with urethral inflammation, that was 2 dogs. They all had their stents removed at days 5 and 13. Both of those dogs did well during that time period, and their stents remained patent. There was the one dog that was recovering from a urethral tear. That dog had the stent removed at day 9, and again did well, and the stent remained patent as well. And then for the functional outflow obstruction dogs, there was 2 dogs. One dog had the stent migrate at day 13 and then was ultimately euthanized. And then there was the other dog. They removed the stent at 11 days to see how he would do, and he didn't do well, and so he was euthanized, which not necessarily surprising for that disease, as some dogs with functional outflow obstruction just don't respond well and end up being euthanized. So complications, again, 16 of the 17 dogs did have some degree of urinary incontinence. They didn't really classify if that urinary continence was mild, moderate, or severe. The stent migrated in 3 dogs, and then 3 dogs, they did have an infection noted on urine culture, but only 4 dogs total were cultured during their time frame of having the stent in place. So it was actually 3 of 4 dogs who had a culture. So it's possible more had an infection but didn't have clinical signs. So 1 dog grew enterococcus, 1 dog grew Pseudomonas, enterococcus, and E. coli, and then 1 dog grew staph. But they did note that actually all 3 of these dogs had had a positive culture prior to stent placement, so we're unsure if it was persistent or recurrent at that time. So this is an overall chart of all 17 dogs. And so the nice thing is that you can see the duration in that the stents were in place. So the longest duration was this dog down here with an anal gland adenocarcinoma, had that stent in place for 337 days. And then shortest duration was a golden with lymphoma, had the stent only placed for 1 day, but that dog, I think, was euthanized like that following day just due to the severity of the disease. Or no, I'm sorry, that was the dog that then went on to have a urethrostomy. But the rest of the dogs, you can see looking at incontinence, migration, and urine infection. And then most of these dogs had their stents in place for kind of on an average of maybe 2 weeks to 2 months or so. So not super long. Limitations of the study. So they did not assess really stent comfort at the time. So there was no kind of owner questionnaires or input from the clients of how the dogs truly did. It was retrospective in a small sample size. And then that it was a single operator and institution. So I wanted to give one case example. Again, we've been utilizing this more and more frequently. I tried to get a total number of dogs that we've done here at NC State, but wasn't able to get it before today because it's kind of hard. We don't really document it that well. So this was Andy, 11-year-old female spayed mixed breed dog. She had presented to her primary vet in fall of 2023 for lower urinary tract signs, and she was diagnosed with a bladder mass via ultrasound. She was referred to our oncology service that following month, and they found a large proximal urethral mass and bladder wall thickening. She was BRAF negative. So they then referred her to NC State Nephrology Urology for a cystoscopy. So this was her cystoscopy images. So she had, we ended up finding a urethral tumor that spanned almost the entire length of the urethra. So you can see the distal opening of the urethra on the top left image. You can kind of see tumor kind of peeking out through the distal urethra, kind of right at the vestibule. And then these other 3 images are varying degrees throughout her urethra of that tumor. And so you can see she was almost completely obstructed. And then we did a fluoroscopy to measure her for a permanent stent. So once we got in for cystoscopy, realized that she actually was too small for TURBT. If she was a larger breed dog, we probably would have used that electrocautery to clear away that tumor. but she actually was too small to fit the scope that contains the electrocautery. So spoke to the owners, and at that time she elected for a permanent stent. So we went during that same anesthesia to fluoroscopy and measured her. You can see based on her fluoro, kind of the extent of her tumor all in her proximal urethra, and kind of some areas expanding down all the way down to her vestibule. So again, we were unable to perform TURP due to her size, so we were able to measure her for a self-expanding permanent stent. But of course, like always, we didn't have that size that we wanted in stock, and she was completely obstructed. And then, like always, it was Friday. So even if we got the stent ordered, the earliest we would get it is Monday or Tuesday. So then, you're trying to think about, what can I do with this dog, and should we just have them sit in hospital over the weekend with an indwelling urinary catheter in. But since she's otherwise healthy and was doing well, it was okay, let's try the temporary urethral stent. So we were able to place a temporary urethral stent under that same anesthetic procedure and cystoscopy. And so she got to go home over the weekend, which I think saved the owner also a lot of money than just her sitting in hospital with an indwelling urethral stent. And then also, got Andy home for the weekend when she was otherwise feeling fine and systemically healthy. And then she came back actually that next week. And that following week, the owner had actually changed her mind and didn't want to do the permanent stent because she was doing really well with the temporary stent in place. And so they went forward and started radiation therapy. Um, and her tumor actually responded really well to radiation, and her temporary stent remained patent until she was able to urinate on her own. So once she started urinating consistently around the stent, we went ahead and pulled it. She did well, and then she was just euthanized this past December. So she lived about 15 months post her diagnosis. So in summary, the temporary stents are relatively easy to place. No real specialized equipment is needed. They often do need really heavy sedation though in males, but probably general anesthesia, especially if you are securing it to the penis and not the prepuce, and then certainly general anesthesia for the females. So far, based on the Lulich's study and our own experience, there seems to be less complications than placing a temporary percutaneous cystotomy catheter. And so for us, it's been a really great option for dogs to either avoid hospitalization for an indwelling catheter. So again, those dogs, while you are waiting for your permanent stent to be in stock, or sending them to radiation or chemo. So it's also been a way we can get them home for the weekend. They don't have to just sit here while we wait. And then we've also have used it, especially for the urothelial carcinoma dogs, when the owner wants to euthanize, but isn't ready to euthanize right then and there in hospital. That's also been a really nice option, because then especially those dogs that are completely obstructed, and the owner really wants to take them home, and you're kind of wondering what to do, just to try to get them home. This has been also a nice way to get them home prior to euthanasia. And so I think that is all I had. So it was pretty short paper. So I want to then hopefully open the floor for discussion, especially hearing other people's experiences if you've placed them, and what the indication for placement is, and what your experience is with them too. So if anyone has any case examples, I'll just open that up for discussion. Or questions too on placement or other ways we've utilized them. Yeah, Dr. Dunn.
Hi, Allie, this is Whitney Vickery.
Hi.
Thank you. That was great discussion. I haven't got to do this yet, but I was curious, slightly off topic. Are you guys using the Storrs resectoscope for the transurethral tumor resection? Or is there another device that you have?
No, that is the one we're doing. Correct me if I'm
Okay.
wrong, Kelly, but I'm like 90% positive it stores, right?
Yeah, it is.
Okay.
But it's kind of one thing I would warn against. They started off with some terp loops that were dead center on the end of the scope, but the recent ones they're sending kind of go off to the side, and we've seen more bleeding with them. So we've had to kind of work with them to bend them more center. I don't know if anybody else that's doing terp is having that issue.
Thanks. I just have unfortunately not run across any cases that are large enough to fit that scope yet. So I'm eager to try it, but I haven't had the right cases. So I'm just curious to hear if anyone has had tips or success or things like that.
Yeah. Yeah, we've and honestly, I've been fairly surprised recently about the size of dogs that we can fit it in. Because it feels like it's not going to fit, but then once you start to chip away the tumor and you open up that urethra, like suddenly all of a sudden it fits. But it's obviously until you've done a few a little bit scary to just kind of start chipping away at tumor when you don't really see the urethra. So you just have to be really, really cautious with that.
Yeah, I would agree. I'd say the first couple ones that we started with, and Allie, you can correct me if I'm not correct, they had like isolated masses within the urethra. And so we were able to get more confident with it. And now we're feeling way more confident. There's also a little mushroom tip that you can use that we have started. You can kind of use it to glide over the tumor, and it kind of melts or burns the tumor below the tip of the mushroom. And we haven't used it to kind of chip away, but I'm wondering if you could also use it to get entry into the ones like Allie just described, maybe a little bit more comfortably than trying to terp and pull away. But we have just started finding that helps a lot. It helps reduce the bleeding, and it really helps kind of smooth out the area when you're finished.
Yeah, the mushroom tip is a little bit harder for actually like debulking the tumor.
Yeah,
But it's really nice for cautery if you start to get a bleeder. A lot of times we'll switch over to that and cauterize things and then go back to the loop. So you can kind of go back and forth too. I saw Marilyn's hand up.
Yeah, thanks for the review. Actually, just now that you're talking about TURB, I just had a question. I haven't used it, but I have just like for localized lesions or just to kind of debulk and then stent afterwards, either with a permanent or temporary. I've like gone in with a diode laser and just kind of done some resection and tried to do it as deep as I could, as safely as I could. And I was kind of disappointed because a few of these cases came back, a couple of months later, and the tumor had pretty much regrown. And so I was just wondering if you had any kind of follow-up, following TURB for urethral cases, if you feel like you get, any kind of long-term. But then I have an actual question about the article you presented too. So.
Yeah, we have, I mean, I will say the majority of our cases we've used TURP on, I will say they typically then follow up with radiation. So that would be the vast majority, although we have one dog who actually belongs to a prior vet student who was, the dog actually was just here last month, that has been through multiple rounds of radiation and chemo and has since failed everything. And so that dog is now just doing TURPed. And so the dog had its first TURPed in like March, and then actually went all the way through till September, not on any chemo or radiation, but I think at that time the tumor was pretty focal and minimal. And then when we scoped the dog in September, which actually that is the dog on my TURPed slide. Let me see if I can go back. Yeah, that's actually this dog here. So this was when we rescoped the dog since in September. So the dog had gone almost about 6 months between TURPed. And this is how bad the tumor had got in that time frame. And so this is where we got the dog in September. And at that point, we had told the owner to just let us know when she started becoming strange uric. But the owner unfortunately didn't really let us know until she was almost completely obstructed again. And then by the time she was able to get to us, the tumor was much worse. And Shelley can talk on that if she wants, because she was the one that saw her most recently. So we decided probably we should have a set schedule to see these dogs back for repeat scope if they're not doing cystoscopy or chemo or radiation to follow up. So yeah, that dog, that 3 months between the second and third terp was too long. So we
Yeah,
probably could have done 2 months.
we've had other dogs that haven't done any additional treatment, and I was expecting that we would be needing to see them like once a month, but I think somewhere around 2 months is probably when you need to go. Somewhere between 1 and 2 months is probably where you need to start going in and cleaning things up a little bit. This particular dog also had tumor in its bladder, and 2 things ended up happening. One is, while we were doing the TERP, the bladder leaked, and so we had to stop the procedure because we didn't want to make things worse, and then we didn't go back and finish it up. But then also that was one of the cases where we were getting a lot of bleeding, and we couldn't really understand that it was because we didn't understand at that point it was because there's a slight bend in that loop that you see there in the newer ones that they sent out that was causing a little bit of bleeding. At least that's what we think was happening. So anyway, we were not as effective with that dog, but I agree that they go much longer than I thought they would. But I think that having them go out more than 2 months before having them come back for a subsequent TERP is probably not in the best interest of the dog.
Okay, thanks. That reassures me that I wasn't just terrible at doing my diode resection, that they do come. So that was a really nice review, Allison. I just had a question because I've done this a number of times using different catheters and that. And then when Jody published the article, I was excited because it kind of gave me other ideas. But one of the most challenging parts I found in a male dog is just getting kind of and suturing to the penis is getting like when you try to grab your stent, especially an orange stent, an orange rubber like catheter, is that it's hard to actually get through it and then pull through, and then you don't know if you actually have the catheter or not, and then you pull the catheter, you realize you haven't grabbed the catheter. At one point I grabbed too much of the catheter and I kinked it off, and so I don't know if you had kind of problems with that. And so the last case I did actually had a expired T-fastener, because T-fasteners are expensive. They're a couple $100, at least Canadian. So it kind of negates putting in a cheap catheter when you're using like a $300 suture to suture in place. But the T-fastener, I was able to kind of get into the lumen, push it out, and then that held, and it was easy to suture. But I was really just me who just had some kind of challenging male cases, or if you also had kind of problems getting a nice, proper one wall the catheter.
Yeah, I think the males are harder than the females, which like when we first started, it was like, oh, the males will be really easy because males are easy to catheterize. But what we've done too is like start our initial bite kind of where we want the end of the catheter, and then I just pull the catheter out and loop it around the anchoring loop coming out of the tip of the penis, and then kind of put my needle back up the urethra and back out that same hole. And then when I pull that suture tight, it pulls the catheter back in. And then I know for sure that the suture is through that anchoring loop. Does that make sense? That's the only thing I found that has helped.
So you're actually doing it outside?
Yes.
Yeah. Okay.
Yeah, like pulling the whole tip of the catheter back out, so I confirm that my needle went through that anchoring loop.
Yeah. Okay.
The other thing I would add to that is that at least at our institution, the more expensive catheters are a little bit softer and more flexible. And in our hands, they are the ones that are more likely to be dislodged than the red rubber ones. And so I actually want to use the red rubber ones. I don't know if anybody else has had that experience with
זהו, שאלה שלך את זה, יש תיאור לגבי אחד, that's urethral resection of bladder tumor.
I don't know if that was a question or an unmute.
I've used the Mila catheters, but in like female cats or smaller. they're easier to suture in place. I find they're more comfortable than the red rubber. I haven't had the red rubber migrate more, and I agree with you, Allison. You know, some of them leave the hospital and they're supposed to be temporary, and then they go to their vet, and I assume they're going to be euthanized, and suddenly they pop back 6 months later and this temporary stent's still in place and they're doing great, and that, so it's kind of nice. And then sometimes I've had people put money aside and put a more permanent stent, or they haven't wanted to, but you know, we call them temporary, but yeah. Sometimes, you know, be permanent if they're well tolerated and they don't migrate. So it's kind of a nice solution. I think it saves a lot of lives. So it's nice. I'm glad you did this because it helps get the word out. So I'm glad you chose this article.
Yeah, thanks. Yeah, I realized when I was talking to another internist in private practice, and he had called me because he had a urethral obstruction. The owner didn't have any money, and I realized when I sent him this paper that he had never seen it before, and he realized how easy it was to place, and that dog is doing really well. So, but yeah, that's exactly what happened with Andy, is that we had ordered the dog her permanent stent and we're ready to place it. And then on Monday, the owner's like, well, actually she's doing really well, so I'm just going to leave this one in. So it's much cheaper. And then she went through with radiation. That the dog did great, and we avoided a stent through her whole time that she had. Does anyone else have any questions or experience to share? And I agree with what Shelley said too. I think that actually the firmer red rubbers also in the females stay in better, because I found the flexibles, they're able to like get those ones flipped around and then more likely to pee out, and then they like come in with this catheter still sutured to their vestibule, just like hanging out. So I find that the red rubbers, I feel like it's easier, it's harder for them to pee out because they're stiffer. Okay. Well, I guess we can end there. Unless anyone has anything else, or if Summer has anything else to announce.
I don't. Thank you so much. This is great discussion.
Great. Thank you.
Everybody have a great day.